First of all, thank you, Dr. Akash Singh and team of IDCM for inviting me. And for this particular lecture, these are my financial disclosure. Today I'm going to talk on very important aspect of diabetes management as always for last 100 years, and that is when patient needs insulin, patient needs insulin. Now, when we want to start insulin therapy, the first question to be answered is which insulin you would like to start, or is there any other therapy which can control that patient's blood sugar, like adding another OAD, or even as Dr. Rucha described, very nicely described, the molecule semaglutide, GLP-1, because now US FDA is telling that first injectable should be GLP-1 in type 2 diabetic patient. So let's discuss this patient, 52-year-old female, Mrs. Savitha. She is an entrepreneur, sedentary lifestyle, comes for consultation with complaint of tingling in foot, frequent fatigue and lethargy. And she was advised diet. She is not very adherent to her diet, concerned about her busy lifestyle, and she is not able to do the routine prescribed activity also. Now her fasting sugar is 142. Post breakfast sugar is 168, post lunch 148, and post dinner, which is high, that is 264, and HbA1c is pretty high, which is 9.8, with normal creatinine and EGFR level, including patient's BMI, which is 26, slightly on the overweight to obese side, with mild dyslipidemia, that is LDL 126. So obviously not up to the mark as such for cardiovascular protection, and her HbA1c is 11.4. She is non-smoker, non-alcoholic. Now, she is on sitagliptin, metformin, empagliflozin. Her father is having type 2 diabetes history, mother is having type 2 diabetes with CKD, and as she is obese, sedentary, entrepreneur, obviously she was advised GLP-1 analog because that is the first choice in this particular patient, but because of gastric side effect, patient was not happy. Now she is worried. She also knows, because obviously patient Googled and see that now she needs insulin therapy most probably. So she is worried that how I can control my sugar and how I can go with my lifestyle, erratic lifestyle, that I will able to manage my sugar nicely. So we have options. Definitely patient is not all OHs which are available, because we are happy to give quadruple therapy, pentad and hexad as far as our diabetes prescription is concerned. Unless until patient is on all possible OHA, then we put patient on insulin. So we have choice here. You can add OAD, you can initiate insulin therapy. What would you like to do? Patient is on sitagliptin, metformin, empagliflozin. Can we add SU? Yes. Can we add glitazone? Yes. Can we add acarbose or voglibose? Yes. But the answer for that should be weighted enough with side effect, with possible consequences and possible HbA1c control. So this is what data suggests, that if patient is on one OAD and you put patient on second OAD, then you may get HbA1c response very nice, 0.7, 0.9 percentage. If patient is on second OAD, I mean 2 OAD, and now you are adding third OAD, then the response will be around 0.5 percentage. And if you want to add fourth OAD, you may get better control or you may not. Sometimes patient may not respond also. So it all depends which OAD you have used, at which stage of disease you have added, and thereby you may or may not be able to reach the target HbA1c whenever it is needed. And on that other side, from first, second, third or fourth, matlab after first OAD, directly you are putting patient on insulin, patient is on 2 OAD, you are directly putting a patient on the insulin. Patient is on 3 OAD, 4 OAD, 5th OAD, and still thereafter you are putting insulin therapy, it will work. Because insulin is not having any that ceiling effect. You can use 10 unit, you can use 100 units, you can use 180 unit. But problem is not the effect, problem is with psychology of the patient. There are patient barriers which are always there before we start insulin therapy. First fear, any of you, which should be the first fear of this? Hypoglycemia, okay, but usually patients are not that worried about hypoglycemia. Anything else? Needle phobia. So it is very common that patient, I will say not patient, because I am having number of doctors who are consulting me not to take insulin. Because they want કે insulin પહેલા કઈ થઈ શકે કે નહીં. Because it is not about doctor or non-doctor or any other, I mean layman. It is about fear of needles which is there since birth. We are taught like this, and that is the fear of, I mean because of what we are not ready to take injectable therapies so easily. Even Rucha told that when liraglutide was there, liraglutide is there for almost 14 years. How many of your patients really happy with that GLP-1 therapy? And compare it with semaglutide. Semaglutide is used like anything, especially the oral semaglutide. And the injectable one is also once weekly, so people are happy. So that is always there, but we have to overcome that fear one way or other way. And along with that, sometimes cost of therapy may go up. Weight gain may happen because of insulin therapy, because insulin is an anabolic hormone and that is there. Patients are also having mind like this. Change in lifestyle, especially patient like Savitha, who wants a simpler insulin because of her erratic lifestyle, may get worried about change in lifestyle because of that. Psychological effects are always there. Burdensome regimen like basal bolus regimen, when we are giving to the patient directly at the outset for the first time and we are putting patient on 4 times insulin, it is difficult. And the last part is very important, that is insulin literacy. Means what? What is insulin literacy? It is about education related to insulin, how to take insulin, where to take insulin, how to rotate site, how to preserve, how to manage sick days, how to take insulin when they are traveling. They have lots of things. મારી પાસે એક પેશન્ટ આવેલું કે સાહેબ મને ઇન્જેક્શન લેવામાં કંઈ વાંધો નથી, પણ મારું ટ્રાવેલિંગ બહુ હોય, તો હું કઈ રીતે આ બધું કરી શકું? So that was the only fear, that when I am traveling, what I will do. So that type of education is needed. But on the other side, as a physician, we do have barriers to start insulin therapy. Compensation fatigue, burdensome regimen, these are there, because sometimes as an endocrinologist level or diabetologist level, we have support staff who can educate patient nicely, everything is done properly, so patients are also ready to take basal bolus regimen very easily. But at physician level, sometimes at a general practitioner level, you need more simplified approach because of the lack of resources. At the same time, lack of time given to the patient is always a challenge, especially in India, because we hardly get 2 minutes, 3 minutes, 5 minutes to talk to the patient, because long queue is waiting outside your chamber, and sometimes that is not enough to convince patient to take insulin. Poor or inadequate communication is another problem, that even if you have time, if you don't explain the disease, if you want to start insulin, just don't write insulin. Tell patient why you have written insulin, describe basic deficiency of insulin along with insulin resistance in type 2 diabetes, and certain point of time due to beta cell failure you need insulin therapy, that is to be explained. And fear of doctor shopping is always there because it's a competitive market, so we feel that if I am not comply with the patient's expectation, then patient will go to the other doctor. And adverse effect of insulin therapy, specifically here I will say hypoglycemia. We are so much worried about hypoglycemia. If we start basal insulin of 10 unit, we don't increase 10 unit to 14 unit for next 1 to 3 months. We are waiting that patient sugar will come down, and patient is going with 200 and 300 sugar even after insulin initiation. So that is what is lacking from our side also. So when you want to start conversation shortly after diagnosis, always first time patient is coming to you for the first time with 300 sugar, I know you all are going to, even I am going to put type 2 diabetic patient, insulin naive patient, treatment naive patient on oral drug therapy, because most of the time patient comply to oral drug therapy well. But still at that time explain and educate. Then whenever it is needed, sit together, develop a plan together and set up an expectation. That is what all guidelines suggest. So RSADI 2022 guidelines suggest that if patient is failing to achieve glycemic target on 3 oral drugs, you may initiate insulin therapy. Insulin therapy should be simple enough. Providers should using insulin, should avoid using insulin as a threat or describing it as a sign of personal failure. Because you are not doing anything, I am giving you insulin. No, because you need insulin, that's why I am giving this thing. So when we are talking about insulin initiation and when we want to give some insulin therapy, we have one good option, that is a combination of insulin degludec and insulin aspart, that is Rhizodec, available with us. But when we want to give this in place of routine basal insulin, there are few parameters on which this insulin should pass: lowering hypoglycemia, mealtime flexibility, simple regimen, convenience of device, better quality of life, cost effectiveness, and obviously efficacy. So if this insulin passes over this merit, then yes, it can be given as a first choice to your patient when you start insulin therapy. So as an Asian Indian phenotype, we all are having diabetes comparatively a decade earlier than Western population. Pre-diabetes to diabetes conversion rate is high and faster. Though we are thin Indian, we are fat Indian, our abdominal fat and overall inflammatory fat is high. Increased insulin resistance even at low level of body mass index is also common, and beta cell dysfunction and inflammation, again I am putting more emphasis on inflammation, is much more in comparison to Caucasian population, and we are carbohydrate eater. See the data of STAR study from Western, Eastern, Southern, Northern, Central India. Everywhere we eat carbohydrate. We are eating almost 61 to 70% of our total calorie intake in form of carbohydrate. And more than 83% of the participants who were in this study were having PPG of more than 160. So we are carb eater, and that's why if you give basal insulin alone, it will bring down the chronic sustained hyperglycemia, but the peak which is going on after having rich carbohydrate rich meal will still go up, and patient will not have a excellent glycemic control. So ultimately they will end up with multiple dose of insulin therapy. As far as therapy is concerned, impact survey suggests 9 out of 10 HCPs preferred an insulin therapy that will control fasting and postprandial level both. And that's why even in Indian scenario, premix insulin are still common to start with as a first injectable therapy. The difference between Asian and non-Asian patient with type 2 diabetes, you can see when you give basal insulin, 46% of non-Asian in comparison to only 39% who achieved HbA1c of 7. So that is very important, that we need something to target at least 1 or 2 postprandial peak which are there because of our carbohydrate rich meal. And IDegAsp gives us that answer because it contains 30% insulin aspart and 70% is the ultra long acting insulin degludec. So whom can we prescribe? Patient who are uncontrolled on OD, like Savita, our case patient, need of safety and flexibility at initiation. Now, if patient is already on basal insulin and patient is having hypoglycemia, which is majorly at night, or patient is having unacceptable weight gain and the dose of basal is increasing, but the postprandial peaks are not coming down, and still patient is need of flexibility, you may think of either IDegAsp, or if patient is okay with that, then basal bolus regimen is always gold standard in such type of patient. But when you need safety, obviously you need milder agent instead of an aggressive therapy, and that's why you tend to use only basal insulin in elderly, frail, hepatic impairment, renal impairment, fasting condition and erratic meal pattern. But actually these are the patients where even IDegAsp can be given safely. Premix insulin patient who are not controlled, especially the postprandial peak is more, you may see premix insulin to 2 times this insulin degludec aspart combination, and patient who is on basal bolus regimen, it's a gold standard. So if patient is okay and patient is happy with that, then don't reduce to this Rhizodec twice. But if patient is having problem with this, or patient is not taking 1 or 2 shot properly, because of that his HbA1c is not under control, and patient need that, I will not say flexibility, but convenience, then giving this IDegAsp twice daily in such type of patient is a good option. This is comparison of IDegAsp in comparison to glargine U100 and glargine 300 as far as efficacy is concerned. You can see IDegAsp is better in comparison to basal alone, and that is mainly contributed by postprandial control along with similar fasting control with all this basal insulin, either degludec or glargine. Safety and insulin dose is also described in this particular slide, where you can see even after there is a small 30% postprandial component, patients are not developing significant nocturnal or severe hypoglycemia in comparison to basal alone. And insulin doses is also not that greatly varied. As far as switching to IDegAsp from glargine U100 or 300 is concerned, we have efficacy data, we have quality of life data, we have safety data, and we have treatment preference data with this particular study. Quality of life, patients who were on IDegAsp were more happy as far as satisfactory result with the treatment is concerned, that is 70% in comparison to 67%. Quality of life questionnaire, 26 questions were asked related to insulin therapy and satisfaction, and in this quality of life 89, 86 and 94% respectively accepted this treatment as improvement with reduced prick, more comfortable to injection and managing day-to-day activity with this particular injection. What about pill burden? See, whenever you give insulin therapy, and especially if insulin therapy doses is going 0.4 to 0.5 unit per kg, beyond that level, usually sulfonylurea is not working. Sometimes if patient is pioglitazone is not working, we can reduce that pill burden which are going on unnecessarily and giving no extra benefit to the patient. So 70% and 50% respectively from 3 OAD to 2 OAD or 2 OAD to 1 OAD is also possible, but it depends patient to patient. So it's not, this is one study, but maybe in clinical practice from patient to patient this may vary. But the best thing I like with this particular injection is flexibility in dosing. You can give before breakfast, you can give before lunch, or you can give before dinner. Where you will give? You will give this injection when patient is having highest glycemic load in form of carbohydrate. So if patient's lunch is super and dinner is okay, then give it at lunch time. If patient is not eating throughout the day and the supper is the best meal of the day, then give it before dinner. Start with 10 unit of IDegAsp and how to titrate? Same like all other basal insulin. Forget about that aspart component. You have to fix the fasting first, and if postprandial peaks are there, then you may think of giving this injection twice or adding short acting aspart at that particular meal. And when you want to put it BID, you may split according to carbohydrate. If so, patient carbohydrate meal to standard meal, then split to 1:1. If night meal is super and lunch meal is working, then you may have 1/3 and 2/3 dosing also, because we have to control the postprandial peak also. As far as cost effectiveness, because obviously the newer insulins are costlier than older insulins. So this is one study that all treatment costs, yearly cost of this IDegAsp with consideration of medication and healthcare resources, that is outpatient visit, emergency room visit, inpatient hospitalization and workday missed, and you can see that yearly cost difference, patients who were on IDegAsp in comparison to other treatment were lesser by almost 3,000 rupees. So this is more of a statistical data, important for insurance policies and everything, not for us, but this is for us to understand this, that sometimes we feel newer therapies are costly, but in turn sometimes it giving reduced cost burden to the patient because of lesser complications. So switching from IDegAsp from other insulin regimen, if patient is on basal insulin, just if patient is on 18 unit of insulin glargine, and if you want to put on Rhizodec, directly 18 unit of Rhizodec to be given. If pre-mix insulin, you may still divide this in 1:1 by giving 2 times basal insulin with this aspart combination. If premix BID is there, 100% we are going to give Rhizodec also BID. If premix is OD, and if you want to have a better control, you may think of OD or BD as per the patient's glycemic profile. And if patient is on premix TID, premix TID is not for human insulin, it is for insulin analog with 50-50 proportion, where patient are on 3 times premix insulin, and if you want to put patient on 2 times, then that is IDegAsp BID. Now here one thing I would like to emphasize, that pre-mix insulin and this IDegAsp, though both are 30-70 proportion, are not same. Why? Because this is a co-formulation, this is 2 different injections which are in same pen. While in premix insulin, it is same insulin which is either plain or with NPH. So what is the difference? That premix insulin is, the time action profile of insulin is elongated because of NPH, while it is not affected here by any other extra supplement. These 2 different insulin, and this actually works as a basal plus therapy. So if you give 2 times Rhizodec, it is 2 separate short acting injection with 1 basal. So it is like basal plus 2 therapy. The only thing, the difference between Rhizodec and basal bolus therapy is more flexibility with basal bolus regimen, which is not there with Rhizodec. But for type 2 diabetic, most of our routine type 2 diabetic patient, we don't need flexibility. But if somebody asks me, will you put type 1 patient on Rhizodec? No. Why? Because I want more flexibility in type 1 diabetic patient. Will you put LADA patient on this Rhizodec? No, because they need more flexibility. But still there is one possibility, that if patient is having significant standard meal, 1 time Rhizodec with 2 other rapid acting analog or 3 other rapid acting analog is even possible with type 1 and LADA, but that is not a first choice just because of flexibility. So this is what we have to do, and accordingly we can shift this regimen from different regimen. So IDegAsp is a choice at insulin initiation because risk of hypoglycemia is low, like other basal insulin. Mealtime flexibility is there. Regimen is still simple, though it is targeting 2 different parts, FPG and PPG. Convenience of device is always there with no pen, it is always there. better quality of life, quality questionnaire test suggests this. Cost effectiveness I have already described, and efficacy, we all know about different efficacy, because ultimately insulin efficacy is same for all insulin. It is about flexibility, it is about time action profile, it is about different molecule, but the efficacy is always there. So with this, again, if I am asking you people that would you like to try Rhizodec here? So these patients were put on insulin IDegAsp combination 18 units before dinner. Why? Remember, her postprandial sugar was 264 and fasting pre-lunch, post-lunch, post-breakfast was around 140, 160. So such type of patient needs basal insulin therapy to bring down this level to 90, 100, and one significant postprandial meal peak will be covered by this aspart part. And you can see after 3 months, HbA1c, which was 9.8, came down to 7.2, fasting sugar 142 came down to 110, and 284 post dinner sugar came down to 136. And because it's a simple single therapy which can be taken just before meal, is not making her life intolerant to insulin therapy, and she is fine with that. So this is what this insulin aspart and degludec combination will have. Thank you all of you.